Very good morning to all of you. So my topic is YAG PI in glaucoma, when to decide. Straight away going into the indications, primary angle closure disease is the most common indication for YAG iridotomy. Then we have plateau iris, which again belongs to primary angle closure. Then acute primary angle closure, secondary angle closures with pupillary block, and the less common indications include nanophthalmos, microspirophakia, aqueous misdirection, and all generation phakic IOLs. Primary angle closure disease is the most common indication for a YAG iridotomy. Here the mechanism, there is a related pupillary block because of various anatomic and physiologic factors, and the aqueous faces a resistance for the outflow from the posterior chamber to the anterior chamber. Aqueous gets trapped behind the iris and drives the iris forward. So by using a focused laser energy onto the iris, you create a hole which allows the aqueous to flow both through the iridotomy and through the pupil, relieving the pupillary block. So primary angle closure disease is a spectrum which consists of primary angle closure suspect, where you have more than 180 degree of iridotrabecular contact, but the intraocular pressure is normal, there is no peripheral anterior synechiae, and the optic nerve head is also normal. When it comes to primary angle closure, along with the iridotrabecular contact, you get elevated intraocular pressure or peripheral anterior synechiae or both, but the optic nerve head is normal. When the optic nerve head is also affected, it becomes primary angle closure glaucoma. So regarding YAG PI in primary angle closure disease, in primary angle closure glaucoma, there is no doubt you have to definitely do API. There is some controversy as to whether YAG PI is going to help when there is extensive synechial angle closure, but the current dictum is even if there is extensive closure, you have to definitely do a YAG iridotomy. In primary angle closure also, you have to do a YAG iridotomy, and the dilemma is only with regard to primary angle closure suspect. So let's see the natural history of the disease. This is from the Vellore eye study, where they followed up the patients for 5 years, and they found that 22% of the primary angle closure suspect gets converted to primary angle closure, and 28.5% of primary angle closure gets converted to primary angle closure glaucoma. The Hanton eye study, they found that PACS conversion to PAC and PACG was 6%. So the Asian literature, the incidence of PAC and PACG varies from 5 to 25%. So now the key question is there any benefit for doing PI to prevent primary angle closure? So let's see what does the literature say. So this is the SAP trial, or the Hongshan Angle Closure Prevention Trial, which is a population-based study conducted in the southern province of Hongshan in China, where they screened around 12,000 people for PACS and enrolled 889 asymptomatic PACS patients, and one eye was treated with laser PI and the other eye served as control. So almost all the confounding factors were eliminated, and the outcomes measured were acute angle closure, raised intraocular pressure, and peripheral anterior synechiae. And this was the 6-year outcome of the SAP trial. Acute angle closure developed in 5 of the control eyes and 1 of the LPI treated eyes, out of which 3 controls and 1 treated eye developed acute angle closure after dilatation, that is after getting exposed to a provocating factor. Raised intraocular pressure was noted in 5 control eyes and 3 LPI treated eyes, and PAS more than 1 clocker was noted in 30 control eyes and 15 LPI treated eyes. The 14-year outcome of the SAP trial was published in 2022, where again the outcomes measured were same, and they found that a total of 33 LPI treated eyes and 105 control eyes reached the primary endpoint. And the conclusion was, despite a 2/3 decrease in PAC occurrence after LPI, the cumulative risk of progression was relatively low in a community-based PACS population over 14 years. One important point to be noted, that is, while the study was extended from 6 to 14 years, the number needed to treat to prevent an endpoint dropped from 44 to 12.35, highlighting that over long-term LPI was found to be more beneficial. Then we have the ANALYSIS trial, that is the Singapore asymptomatic narrow angle laser iridotomy study, where again it was a multicentric trial. 480 asymptomatic PACS patients older than 50 years were included. One eye underwent LPI and the other eye was controlled. Outcome measures were PAC, acute angle closure, and PACG. And the results were that older patients and eyes with higher baseline intraocular pressure were more likely to reach endpoint, and the number needed to treat to prevent an endpoint was 22. And the conclusion was, LPI-treated eyes reached significantly lower endpoint compared to the controls. However, the overall incidence of PAC and PACG was low. So definitely you need not treat all PACS patients. So now the question is when to do LPI in primary angle closure suspects. The indications include, one is the need for frequent dilated fundus examination. This is quite significant in our scenario where we have a large diabetic population. Then in one-eyed individuals and in patients with symptoms concerning to intermittent angle closure and those living in remote area with poor access to healthcare, those with strong family history of primary angle closure glaucoma, and those patients who are on antidepressants or drugs with anticholinergic action. This has been termed as the PACS plus group. Now, another scenario is when the patient comes with a cataract and a shallow AC, what has to be done? You have two options. One is do a YAG PI, do a dilated fundus examination, and then proceed with cataract surgery. Or straight away, you can go in for cataract surgery, but dilate the patient only in the operating room after giving IV mannitol. I prefer to go the first route because technically a YAG PI makes the surgery more easier, and also a dilated fundus examination helps you to rule out any coexisting fundus pathology, especially if the patient is going in for any premium IOLs. So coming to the less common indication, then plateau iris, it is caused by an anteriorly positioned ciliary body. Laser iridotomy must be the first choice of treatment. Thereafter only you consider iridoplasty, topical pilocarpine, and the rest of the treatments. Then in acute angle closure glaucoma, definitely you have to do a laser iridotomy, but it may not be possible on the first day because you have an edematous cornea. So initially treat the patient with IV mannitol, oral acetazolamide, topical anti-glaucoma medications and steroids. And once the cornea clears, you have to do a laser iridotomy. Avoid extreme periphery because the AC is very shallow and you are likely to get corneal burns. Give post-laser steroids, and always treat the contralateral eye because around 50% of the patients suffer a second attack in the fellow eye over a 5-year period. Now, in phacomorphic glaucoma, it is the intumescent lens which is the culprit that causes angle closure. Lens removal is the definitive management. PI can be a temporary measure, but always be careful. Any accidental shot onto the anterior lens capsule will result in a phacolytic glaucoma. In uveitic angle closures, when there is extensive posterior synechiae, there can be iris bombay and angle closure. PI is the definitive management. Do the PI on the most convex area of the iris. Since there is active inflammation, there is a chance that your PI can get closed. So do multiple PIs post-laser, cover with topical steroids and mydriatic cycloplegics. Then in secondary angle closures with pupillary block due to subluxated lens, laser iridotomy can relieve the pupillary block. You suspect a subluxated lens when you have a disparity in AC depth between two eyes, either from your clinical examination or from the biometry. When you compare the biometry of the two eyes, when there is an AC depth disparity, suspect a subluxated lens. A laser iridotomy can be done. In a dislocated lens in the anterior chamber, it can cause a pupillary block. Laser iridotomy is a temporary measure, but the definitive management is the lens removal. In malignant glaucoma, always do a laser iridotomy. First, eliminate any coexisting pupillary block, then only you think of malignant glaucoma and the further management. So to conclude, PAC and PACG are definitive indications for laser iridotomy. You need not treat all PACS patients. Consider patient risk factors before deciding on laser PI in PACS patients. And whenever you decide to observe a PACS patient, please do warn of the symptoms of acute angle closure. Thank you.
Thank you, Dr. Litta. That was indications for YAG